Hi, Dr. Ding and Dr. Benjamin. Are we okay to start?
Yep, I'm great.
So it's already 3 o'clock. Good afternoon, everyone. So welcome back to our second week of our webinar. So we are continuing with our rheumatology series today. So I'll introduce our chairperson today. So our chairperson today is Dr. Ding Hui Jian. She's obtained her MRCP in 2006 and practicing as rheumatologist since 2014, and she's now the head of rheumatology unit in Hospital Kuala Lumpur since 2024. Dr. Ting is well known for her dedication not only to the patient care, also contributes significantly to teaching and also research. So we are honored to have her today. So I'll pass over to Dr. Ting.
Hi, good afternoon. Can you all hear me? Okay. So today we're going to go ahead with session 2 of the Rheumatology month. So we have Dr. Benjamin from Kota Baru giving the talk on vasculitis updates, vasculitis unveiled, practical skills for the frontline clinician. Vasculitis is a lot of us will know is the bane of many doctors, the rheumatologists, because it can be sneaky. Sometimes it takes a while to make a diagnosis. Sometimes it stares at you in the face. But rheumatologitis is also difficult to treat and expensive to treat. But if treated well and early, it's very rewarding. But sometimes it's so severe it causes damage like renal failure, limb loss, and poor quality of life. So it's important for us to recognize or have a suspicion that this could be vasculitis and get it referred early to the rheumatologist. So we have Dr. Benjamin to give us a talk about it. But before go, go to the lecture, we'll give you a short overview of who Dr. Benjamin is. He's a rheumatologist and physician in Hospital Raja Perempuan Zainab 2, Kota Baru. He qualified as a rheumatologist in 2023, and he has been very active in the local rheumatology scene with with the rheumatology education and research. He's published a lot. He's got quite a lot in numerous papers and has also been a peer reviewer for some journals. He is an active member of the MSR and the Malaysian Young Rheumatology Society, and he's been very active in organizing educational activities for the trainees in Malaysia. Um, his key interests are lupus, inflammatory myopathies, vasculitis, and medical education. And I think there is no better person to give a talk on vasculitis than Dr. Benjamin. So I'll pass the floor to you, Dr. Benjamin.
Right, thank you, Dr. Ding. Okay, so today we're going to go through vasculitis. Let me just share my slides so that everyone can have a look. I will be kind of turning off my camera because my internet connection is slightly unstable today. So hopefully that will improve the bandwidth for everyone. But let me just share the slides first. Here we go. Okay, turn this off. Okay, good. So, all right. Just we can see, make sure. Okay, great. So everyone's able to see that. Right, controls. Okay, great. So good afternoon, everyone. Thank you to the College of Physicians, for giving me this chance to, share with you a little bit about vasculitis. So I am Benjamin, and I'm a rheumatologist and physician currently located in Kelantan, Hospital Raja Perempuan Zainab 2. And today I've been given this task of talking about vasculitis, and I think it's a very big topic. It's a very interesting topic, and not many people really do understand it. I think when I first started off as well, it was kind of, a mystery to me. And as time progressed, we learn a bit more and we can understand it better. So these are my disclosures. So there are some slides that I would recommend you do not take photos of. I think those will have a picture sign there. And the views and of course the opinions expressed in this presentation do not reflect those of any of the units or the College of Physicians of Malaysia. So starting off, we have some learning objectives. So by the end of this talk, what I do hope is that all of us are able to actually describe the spectrum and clinical relevance of systemic vasculitis, classify them according to vessel size, identify components required to make a diagnosis of vasculitis, apply some key questions that I think is very important. So these are questions that I ask myself all the time when I'm looking at vasculitis. And finally, appreciate the need to differentiate vasculitis from its mimickers. And mimickers are quite a lot and abound in vasculitis. So the outline of our talk today would be an introduction, talking about classification, talking about making the diagnosis of vasculitis. And I believe there are 6 essential components to that. We talk about an approach to vasculitis, and I'll show you how I use my 5 questions to ask when we actually approach a patient with vasculitis, and I'll give you an overview of treatment principles. We will not go through specific vasculitis today, like large vessel, medium vessel, or small vessel, and we will not go through their specific management. This is kind of like a run-through or a sprint throughout vasculitis, and it is meant to give you a guide on how you want to approach it and how you want to think about vasculitis. So let's start with an introduction. So systemic vasculitis is basically a heterogeneous group of chronic inflammatory diseases, which is characterized by blood vessel inflammation. So, when we talk about inflammation, we're talking about blood vessel inflammation. And when there is blood vessel inflammation, what can happen is that you can have reduced perfusion to the end organ. And ultimately, it leads to what we call organ ischemia or damage. It can be localized vasculitis, localized to the skin, localized to the kidney, or it can be a generalized systemic vasculitis. And these are the 2 kind of groups that we think about when we talk about vasculitis. It is a rare disease, so by no means and purposes vasculitis is very common. But secondary vasculitis or mimickers of vasculitis are more common than what we call as primary systemic vasculitis, which is what we are very aware of. Things like Takayasu's, giant cell arthritis, polyarthritis nodosa, things like Wegener's or EGPA or GPA. Those are fairly rare compared to what we call as secondary vasculitis, vasculitis due to CTD or other causes, or mimickers of vasculitis. So if you were to look at this particular table here, you would find that actually the most common vasculitis or the incidence of vasculitis would probably be HSP, which I think most of us have seen at some point of time. Now, the classification of primary vasculitis has been also extrapolated to look at patients with secondary, and we kind of like get our know-hows and understanding of vasculitis from the primary vasculitis. And we classify vasculitis based on its vessel sizes. So when we talk about vasculitis, we think about large, medium, and small vessels. But what does this actually mean? So large vessels are what we call the aorta and its major branches. Medium vessels are main visceral arteries and veins and their initial branches as well. And small vessels will be intraparenchymal arteries, arterioles, capillaries, venules, and veins. And these would tend to be in the skin, tend to be in the kidney, glomerulonephritis, and things like that. We are very well aware of this particular picture, and I think no vasculitis talk would be complete without this picture being shown. And what this shows to us is the different types of vasculitis according to the Chapel Hill Consensus Conference nomenclature. And so when we talk about large vessel, we think about things like Takayasu's and giant cell arthritis. When we talk about small vessel, we think about ANCAs, we think about immune complexes, and when we talk about medium vessels, we think about things like polyarthritis nodosa and Kawasaki's disease. Behçet's disease is also classified as a vasculitis, but it's what we call a variable vessel vasculitis, affecting any form of the vessels. The classification of vasculitis has gone through quite a bit of changes over the years. In the 1860s, it was actually initially first described as periarthritis nodosa, which was first described as a distinct disease entity. And moving on in time, we have got in 1990s the first set of classification criteria that was actually endorsed by the ACR. And subsequently in 1994 is this Chapel Hill Consensus Conference nomenclature, which was first introduced. So trying to classify or trying to name the vasculitis based on the syndromes that actually present. And this was further developed to include NCAR in 2012, which is what we are very aware of nowadays, which is the picture you saw previously. And in the 2022, which is most recently, the ACR and EULA, which is the American College and the European League of Arthritis and Rheumatism, developed a classification criteria for 5 different types of vasculitis based on a study that was done, the DCVAS. And we'll go through this in a bit. You don't need to remember this, but you just need to appreciate that our understanding of vasculitis has changed from knowing it as vasculitis, systemic vasculitis, to dividing it into large, medium, and small vessels, and then adding on serology such as NCAS, and now trying to develop a weighted criteria to further classify them and to further be more specific in our diagnosis of vasculitis. The CHCC nomenclature is actually a nomenclature system. It is neither a classification nor a diagnostic system. So what it does is that it actually specifies a name that should be used for a specifically defined disease process. And I think all of us have kind of grown up with this consensus conference nomenclature, because when we ask you, or we know when you go to exams, or when you think about it, you say, oh, this is an elderly lady, presents with temporal headache over the right side, and the temporal artery is, tender, and then, it's bounding, and then she has got some eye problem, or loss of vision. Then you say, oh, this sounds like a large vessel, this sounds like giant cell arthritis. Or we, at the same time, in the same vein for large vessel vasculitis, you say that, oh, this patient presents with, pulselessness, differential pulselessness, and you think, oh, this is a young person, probably Takayasu's arthritis. And this is what it looks like to all of us. We see vasculitis as a large heading, and we move on to smaller headings such as large vessel, medium vessel, small vessel, variable vessel. And of course, we have single organ vasculitis such as isolated iotitis, primary CNS vasculitis, and vasculitis associated with systemic diseases such as the rheumatoid vasculitis or SLE-related vasculitis, and also those associated probable etiology. So if you were to look at this consensus conference, you find that they're not trying to tell you what is which, how to diagnose it. They're just trying to tell you this is a name for the group of, this is a name for the syndrome that we see, and this is what you should call it. And subsequently, we moved on to try to develop classification criteria for these. So this DCVAS is something that is quite new, and it has produced quite a number of papers. It is actually the aim of this study was actually the diagnostic and classification criteria in vasculitis study. Its aim was actually to produce a modern practical classification criteria for major systemic vasculitis. It's used interchangeably as a diagnostic criteria, but its main purpose is classification and not for diagnosis. Over 7,000 patients from 32 different countries. And these cases that was chosen were high certainty cases, and subsequently they used statistical modeling to try to come up with a classification criteria. So let me show you an example of two different diseases, so you can kind of appreciate where we were at in 1990 and where we are at currently in 2025. So in 1990, when we were to try to classify Takayasu's, we say, yes, if you have age less than 40, some claudication, decreased brachial artery pulse, BP difference, some bruit, or some arteriogram abnormality, you've got 3 out of 6 of these, you are more likely to have a Takayasu's arthritis. And so this is where we came from. And now with this DCVAS, what happens is that they have named and they have defined what are absolute requirements for you to say this patient has Takayasu's arthritis. So absolutely, if the patient is less than 60 years old, has vasculitis on imaging. So these are absolute requirements. And if you have got additional criteria, which is weighted based on, the patients that they had in the study, then you add on values, and subsequently, if you have a threshold value of 5 and above, so the diagnostic, the classification is 5 and above, you have a specificity of 96.59 and sensitivity of 89. So this is trying to improve the sensitivity and specificity of our classification criteria. Similarly, when we talk about GPA, last time known as Wegener's granulomatosis, in 1990s, you had these 4 criteria: nasal, oral inflammation, chest radiographs, urinary sediment, and granulomatous inflammation on biopsy. If you have 2 out of 4 of these, then you can classify this patient as having Wegener's granulomatosis. But now, with this current ACR EULAR classification criteria, when they pull all of the patients, they found, if you look at the table at the side there, the first line, it says, if the C-ANCA or the PR3 ANCA is positive, the odds of you having GPA is 142 times more, right? So, but if you had an eosinophil count that was high, it's less likely you have eGPA. And so with all of these, all of this statistical modeling, they came up with clinical criteria and laboratory imaging and biopsy criteria in order to try to classify these patients. So you are classified as having GPA if you have 5 score or more above. And generally, you should have a clinical criteria and an imaging laboratory or biopsy criteria. And very interestingly, these were one of the first few criteria that I am aware of that introduced a negative marking. So if your eosinophil count was more than 1.0, then you would actually take off 4 points from trying to classify this patient as GPA, because we know that GPA generally does not have a high eosinophil count. So this is a negative predictor, and this is something that we look at. Very interestingly, if you were to look at all classification criteria similar to rheumatoid arthritis, SLE, myositis, the second line will always say this: alternative diagnosis mimicking vasculitis should be excluded prior to applying criteria. So if you, for example, you have got some other cause for any of the criteria, then you should not apply this particular criteria and not count them. So this is very important for us to be aware of. These are classification criteria. So then, moving on from there, the more important part for all of us today: how then do we come to a diagnosis of vasculitis? And for me, I think there are 6 essential components, and this was taken up from one of our rheumatology textbooks. And I think these 6 essential components are very, very critical for us when we want to think about vasculitis. The 6 components are these. The first component is that you must recognize that the patient might have vasculitis, and you must recognize that the patient and the fact that the patient has a compatible phenotype, has consistent serology, confirmation by histology, excluding the mimics and secondary causes of vasculitis. And as time progresses, you'll find that there is increased certainty of diagnosis with time. So let's go through these 6 essential components one by one. The first thing, recognizing that the patient might have vasculitis. As Dr. Ding said earlier on, vasculitis is a bane. It's very difficult. And if you don't think about it, you may not recognize it. And why is this diagnosis of vasculitis often very difficult? Because number one, it can have very variable presentations and organ involvements. They can have recurrent real paltrisson asthma. They can have, some form of epistaxis, which, comes off and on. And they may see different doctors at different times. And it's very difficult to put everything together at one go. There is a very wide clinical spectrum, from mild skin rashes in HSP to severe systemic disease where the patient, has got kidney failure, renal failure, having hemoptysis, needing intubation. And the other part is that there are many mimickers to that, such as infections, malignancies, and other diseases that can look like vasculitis. And the worst part of it all is that there is no specific diagnostic test. Unlike, certain diseases where you can take a test, and say, this is the disease. For vasculitis, unfortunately, sending an ANCA does not mean you have ANCA-associated vasculitis, So this is very, very important. And the difficult part is that if we do not recognize it, and if we do not diagnose it early, we do not treat it well, they can have serious consequences, such as potential for irreversible damage or life-threatening complications. So a pearl that I always think about is this: always consider vasculitis in multisystemic disorders. So if you find a patient comes in with multisystemic disorders, put vasculitis as one of your differential diagnoses as you are working out other causes as well, and think about vasculitis in the end. Vasculitis ultimately is a diagnosis that you have to think of to find. Without thinking of it, you're not able to find it. So when we think about vasculitis and we say, hey, this patient has vasculitis, I think this patient has vasculitis, then you look at the patient's presentation and you see if they're a compatible clinical phenotype. And this vasculitis, and generally the presentation is non-specific. And the diagnosis, as I mentioned, is suggested by multi-organ involvement and compatible laboratory and imaging findings. And what we are looking for, as I highlighted there in yellow, is a compatible phenotype. Then you must ask me, what then is a compatible phenotype? A compatible phenotype is in terms of its vessel size, large vessels, medium vessels, and small vessels. And each of these have their own different symptoms and signs that can kind of lead you on to, hey, this sounds more like a large vessel compared to this sounds more like a small vessel vasculitis. So remember, constitutionally ill and with evidence of multisystemic inflammatory diseases, and if they've got symptoms that is suggestive of large vessels such as limb claudication, bruise, asymmetrical blood pressure, absence of pulses, temporal headache, jaw claudication, then your mind goes more towards large vessel vasculitis like Takayasu's or giant cell arthritis. If the patient has got things like GN, alveolar hemorrhage, pulmonary renal syndrome, you're thinking more small vessel vasculitis, GBM disease, ANCA vasculitis, and so on. If patient has got cutaneous nodules, things like livedo reticularis, digital gangrene, renal vascular hypertension, then you're thinking more along the lines of medium vessel vasculitis, such as polyarthritis nodosa. And so some pearls that I usually would tell people is this: if you have headaches and vision loss in the elderly, you think about GCA. You have asymmetrical pulse with a young age, think of Takayasu's. If you have mononeuritis multiplex, renal artery issues, pulmonary renal vascular hypertension, think about things like polyarthritis nodosa. Rapidly progressive pulmonary renal syndrome, you're thinking of things like ANCA-associated vasculitis and GBM disease. Palpable purpura, you think of immune complex mediated vasculitis such as your IgA vasculitis. And so when you put it all in a table, this table probably be something be very good for you to have a look at. You can find that each of the types of blood vessels that is involved in the sizes have different clinical features that can actually lead you on to where you should investigate and where you should concentrate your effort on. Some history to consider, I think all of us are quite aware of. I've mentioned this quite a few times already, but just to put it in a picture, constitutional symptoms, and if they have got things like ocular, neurological, you want to go through all the history, take a full medical history, go through all the systemic review, look at for things like scleritis, episcleritis, look for like things like pulmonary hemorrhage, look for rashes, think of neurological symptoms, renal symptoms, GI symptoms, and MSK symptoms as well. But what I would like to highlight from this is that do not miss out the past medical history. Ask a very good past medical history, because you may find that the patient has been having asthma for very long, that is very recalcitrant. An example of one of the some of the cases that I've seen over the years was that patients, have had asthma, late onset, treated, for asthma, subsequently never became better. And as time progressed, they start to develop things like wrist drop, some form of neurology. And as you look back and you see that eosinophil count has always been high. And with that, we send some ANCAs and we find that, this patient most likely has eosinophilic granulomatous polyangiitis. And that is the past history is a severe history of asthma that was recalcitrant before. Medication history is important because drug-induced vasculitis is something to consider, especially with all the medications that we're using nowadays. Physical signs that can be elicited, of course, saddle nose deformity, oral ulcers, septal nasal perforation, ENT symptoms, dermatological features, lung, such as crepitations, some abdominal tenderness, especially if they've got features of abdominal angina. I think that will be very important. Also consider things like scrotal tenderness, that will be very, very important in PAN. Pulses, blood pressure, as well as the MSK signs such as arthritis or migratory polyarthritis. So when you put all of the symptoms and the signs together, you can end up coming with a diagnosis. So as I mentioned earlier on, when you have asthma, you think of things like EGPA, you've got things like, sinus involvement, otitis media, you think of GPA or EGPA, absent pulses, you think of Takayasu. So I think all of us are quite well versed with this already. The type of skin lesions that you see, I'll show you a few pictures after this so that you're aware. I'm not a dermatologist, but if you have got things like palpable purpura, pinpoint papules, and urticaria, you think of small vessels. But if you have nodular lesions, livedoid rash, deep ulcers or necrotic ulcers, you think of medium vessel vasculitis. So this is how the skin can become a window to tell you, this is probably what we are dealing with at that point of time. So in small vessels, you can get things like this, purpura or petechial hemorrhagic blisters or urticarial vasculitis. A skin biopsy will always be very helpful. In medium vessels, you can get subcutaneous nodules and ulcers. You can get extensive ulcers as well with some areas of necrosis, and this has some residual atrophic scars. If you have medium vessel, you can get digital necrosis. You can get livedoid rachemosa, which is basically like livedoid reticularis, but it doesn't go away. If you've got retiform purpura, this is what it looks like as well, and some large ulcerations with irregular borders. So you're looking for your history, your examination. What you're looking for is a compatible clinical phenotype towards your large, medium, or small vessel vasculitis, and then you decide your investigations after that. So the next part of the component is to try to find a way to investigate these patients. So once you've decided that this is large, medium, or small, then your investigations will go on in that direction. So usually serology, radiology, and histology will be three key things that we will look at when we're evaluating a patient with potential vasculitis. So the investigation should be guided by the type of vasculitis suspected, and I will stress this very, very seriously. Because if you think the patient has large vessel vasculitis, you are not going to send NCAS and ANAs because there is no value in doing that. On the other hand, if you think that the patient has small vessel vasculitis, you're not going to send the patient for a CT of the aorta. So these are the kind of things that we think about. So there's lab investigations, imaging, and diagnostic procedures. And generally, depending on what type of vessel you think is involved, then you do the investigations appropriate. Usually, large vessel is imaging. Medium vessel you can do imaging biopsies, and small vessel tend to be heavy on the serological testing as well as the biopsies as well. So these are the ways we look at it. There are many blood tests that you can send, but not everything is relevant to the type of to all vasculitis. So if you suspect large vessels, you're not going to send all kinds of immunological testing. You're more likely to send basic bloods, such as what I've listed down over here. But if you think of things like, is this lupus related, or is this, some form of, infection related, or you think this is NCAS, then you would send these kind of tests. But it depends on what you are thinking about. If you think it's pulmonary renal syndrome, then you send NCAS, you send GBMs. If you think that this is lupus, for example, patient presents with arthritis, malar rash, vasculitic skin lesions, patient has got alopecia, then you would think, okay, instead of sending the NCAS, because patient got so many lupus features, I send an ANA and a dsDNA as well. So that will be more helpful to you rather than sending a whole bunch of tests which may not be relevant to the patient, and it becomes difficult to interpret a positive test in the wrong clinical setting. Infective screening, I will always advise to send, such as Hep B, Hep C, and some people would send things like Parvo, CMV, EBV, depending on the situation, and HIV would be something to consider as well. Serologies are definitely helpful for ANCA vasculitis, and we know of the C-ANCAs and the P-ANCAs. And the EULA recommendations for ANCA-associated vasculitis is that we send the PR3 ANCA and MPO by serology in order for us to help to seal the diagnosis of ANCA-associated vasculitis. Remember that a negative ANCA does not exclude AAV. So it still can be AAV, especially if the patient has got EGPA where the ANCAs may not be positive. And on the other hand, if there is a positive serology without the clinical features, do not make a diagnosis of ANCA-associated vasculitis. A diagnosis should never be made with a positive serology alone. And so these are things that I would like to put out there for us to understand. NCAS, remember, like ANAs, like rheumatoid factors, can be found in other conditions. So sending it in the wrong clinical context will end up muddying your diagnostic process, and you become very confused after that. And I will become very confused as well. And remember, ANCAs can be found in GI disorders, inflammation, systemic inflammation or malignancies. Infections can cause ANCAs to be positive, such as TB, bacterial infections, fungal infections, and drugs such as cocaine, hydralazine, PTU, and minocycline. So these things would usually have ANCAs that are positive. Very interestingly, if you have got both the MPO and PR3 positive, there is a thought, that this could be another cause. That means this is most likely not going to be a primary ANCA-associated vasculitis. So we talked about the blood test that you can send. Now we're going to talk about the imaging. And imaging tends to focus around the large vessels and medium vessels vasculitis. Small vessels, probably not so. In large vessel vasculitis, you want to image the part or the suspected vessel that you think is affected. And so in terms of I will show you some pictures after this and show you how to go about it. So in terms of modalities, we have ultrasound, which is very helpful for GCA. We have got MRIs, MRAs, and CTAs, which is good for the aorta. We've got PET-CT, which I always feel that PET-CT is like a cheat code. So you can kind of put it there and you show you where all the inflammation is. And I'll show you a few pictures after this to kind of put my point. And of course, all of them have their own advantages and disadvantages, which I will not go through in too much detail for the fear of time. So where you image depends on where you think the vasculitis is affecting or where the inflammation you think is affecting. So if you think the patient has GCA, you would consider to do a Doppler ultrasound of the temporal arteries. If you think the patient has got Takayasu, then you would do a CT MRI of the aorta. You will look for that. If you think the patient has primary CNS vasculitis, then MRA of the brain. If you think the patient has KN or some form of mesenteric vasculitis or GI vasculitis, then you will think of doing a mesenteric celiac assays or a CTMA. And PET-CTs can tell you where there's vessel wall inflammation. So an example will be this, large vessel vasculitis. You are definitely going to try to image these cranial vessels, and you're also going to try to image the large vessels as well. And this is what it would look like. We have advanced, everyone is using ultrasound, POCUS, and even rheumatologists now are very hands-on with ultrasound. And this is one way we can actually determine whether the patient has got a GCA based on ultrasound without a temporal artery biopsy. And sometimes because temporal artery biopsies are difficult to obtain. In the right clinical setting, when we do an ultrasound, we see this, what we call a halo sign. So you see in the middle here, the first picture, what you can see is that there is a halo around the vessel. And there's also, I notice, hypoechoic kind of a image. So you can see what we call as a halo sign, or if you cannot compress it fully, you can get what we call as a compression sign. So these are ways that we can actually look for GCA. Takayasu, this is a very nice picture which I found on one of the studies. It's a PET MR. So it's a MR with a PET scan. And so you see, right, the first image, you can see where the occlusions or stenosis are. But then when you do the PET, you can see where the inflammation is. And this is one of the great things about PET MRs or PET CTs. You can see where inflammation is. In picture number C, where the red arrow is, you can see at the top, there is actually this thickening over the surrounding vessel. And you see it lights up when they put on the PET scan. CT thorax can show concentric mural thickening. So if you look at the aorta where the arrows are in white, you would see that there is concentric mural thickening along the aorta. If you were to do an invasive angiography, you can see things like irregular tapering and narrowing, so stenosis, and this very famous sign, which is this beading aneurysmal formation. So this is all features of vasculitis. A coronary CTA in patients, you can actually see that there is, over here, you look at the CT coronary. So if you think of Kawasaki's, you're not going to do a CT aortogram, you're going to do a CT of the CT of the coronary arteries. So here you can actually see diffuse aneurysmal dilatation to the LAD, and there is some and of the first diagonal branch as well as the RCA, and this is where the arrows are showing. So these are things that you can actually do. If you were to think about polyarthritis nodosa, you're thinking about the kidneys, and you're thinking about, hey, there are probably microaneurysms. And this MR angiography actually shows that there is some microaneurysms at the lower part of the right kidney, and also there are multiple cortical loss. So you can actually see, right, in the kidney on the left side, there's cortical loss areas. So you see it's not as dense as the other side. If you were to do an angiography for polyarthritis nodosa, you would see aneurysmal lesions in the in the renal arterial branches. And if you did it for the hepatic artery, you can see similar aneurysmal dilatation. And this is why in polyarthritis nodosa, a renal biopsy would not be recommended because there is a risk that you can hit any of these aneurysms. Then about ANCA vasculitis. So I said just now, maybe for ANCA vasculitis, imaging would not be so helpful. But there are instances where it can be helpful. For example, if they have got interstitial lung diseases or they got nodules in the lung, you can biopsy those nodules and you'll probably pick up something. And if they have prominent ENT symptoms, you can probably image the maxillary sinuses and you can find that there is actually a diffuse mucosal thickening. And these are signs, indirect signs to tell you, yes, there is something going on in the ENT side, even though the patient may not tell you of the symptoms. So confirming the vasculitis diagnosis is number one, identifying where the vasculitis is, then trying to get radiological proof of vasculitis or histological proof of vasculitis, and then you associate it with your blood test that's available. So the next part is to try to confirm it by histology. And histology, I think, will be helpful in certain cases. So biopsy, of course, remains the gold standard of diagnosis of vasculitis. So as with most things, you biopsy, you see vasculitis on the HPE, you say, yes, I'm very happy this is vasculitis. But there are a lot of times biopsy is impractical, not practical in vasculitis. For example, large vessel vasculitis or suspicious of PAN. And so we tend to decide on biopsy, the need for biopsy based on the presentation that the patient has. And if you've got things like skin lesions, those will be probably biopsiable, and those will probably be, most of the time, this is what our skin doctors will actually help us to do, biopsy the skin. If you think the patient has GPA, MPA, or they got lung nodules, those things can be biopsied as well. If you think the patient's got GCA, then a temporal artery biopsy can be used, can be helpful as well. Other less common sites such as the testicle, brain, and the sinuses can also be biopsied, but usually this is in consultation with the relevant teams that are involved in doing the biopsy to see if it's probable or possible to do or not without any complications. So when you see histology, there are a few key histological findings. And that is number one, infiltration of the vessel wall with neutrophils, mononuclear cells, and giant cells, fibrinoid necrosis, and leukocytoclasis. And these are the few things that you want to see on the HPE. And this is what you can actually see in the picture here. You can see necrotizing vasculitis in a bowel specimen from a person with polyarthritis nodosa. So you can see the arterial lumen, which is on the left side, is partially occluded by a thrombus. And this is what we're actually seeing, the inflammation that is there. Skin biopsies can show us, this fibrinoid necrosis, which you can see with all of the yellow arrows there over the vessel wall, as well as some form of endothelial thin swelling. This is a biopsy from the lung from a patient with GPA, and they find what they saw here, epithelioid granulomas. So that's actually what you can see here. This is a renal biopsy from a person with microscopic polyangiitis, and you can see necrosis of the glomerular capillaries next to an adjacent non-affected glomerulus. So this is the necrosis that you can see here. So these are the things that you can do. The next part is to exclude mimics and secondary causes of vasculitis. So you kind of now have this, you recognize the patient's vasculitis, you phenotyped it, you did some investigations to recognize it, and then now you're trying to ask yourself, is this primary or is this secondary or something else causing it? So you've confirmed there's a vasculitis, but you're trying to look whether there's another cause for it. So remember to always consider differential diagnosis and exclude potential mimickers. And the mimickers tend to be important because the treatment strategies differ, which is immunosuppression versus antibiotics, immunosuppression versus like chemotherapy, for example, immunosuppression versus stopping the substance abuse such as cocaine. So these are the things. So infections, malignancy, substance abuse, and other systemic autoimmune and inflammatory diseases will be very, very important. So many conditions mimic vasculitis. Infection is a great mimic of vasculitis. And other conditions that we want to consider will be things like APS, TTP, sickle cell disease, some embolization from an atrial myxoma. This is possible. And non-inflammatory vessel wall disorders such as fibromuscular dysplasia, amyloidosis, and vasospasms due to ergots. And when should you suspect mimics? If you have got some of these symptoms. So things like murmurs, significant infections like unusually high fever, liver dysfunction, Hep B, Hep C, history of drug abuse, think of cocaine, neoplastic disease, if you've got necrosis of the lower extremities, think of things like cholesterol emboli as well. And if they've got new medications, think of things like drug-induced vasculitis. So these are the few things. And just to show you that the disorders that can mimic vasculitis in large, medium, and small are non-exhaustive, and there are a lot of things that can mimic. So it is our duty to, when we think of vasculitis, to try to look for other causes in the background in order for us to clinch our diagnosis. Drug-induced vasculitis, ANCA-associated vasculitis, is characterized by the presence of ANCA with a drug causing it. And so there are many drugs, just to show you that many drugs that can be associated with drug-induced vasculitis, but very less common compared to some of the others that we see. So with all of that being said, then you come to understand that as you see the patient, you go through the patient's diagnosis, you go through the patient's diagnostic process, then your certainty of diagnosis of a primary vasculitis versus a secondary or a mimicker becomes increased. So it becomes better as time progresses. So there is increased certainty of diagnosis with time. So that is making the diagnosis. And so then you would have to ask me, you said a lot of things. Now, how do I apply it to my daily practice? And this is what I want to show you, 2 different cases and how I would approach vasculitis. And these 2 cases are generally real cases that I have seen over the years. So 5 important questions that I would ask myself, and I hope that you would ask yourself whenever you think about vasculitis in the future. So I highlight in red, and that's the most important thing. With all connective tissue disease and all rheumatological conditions, a detailed history and physical examination is important because you're trying to exclude other things. And then with this appropriate laboratory imaging and histological testing to kind of confirm your diagnosis or to rule out other causes. And that is the goal of our approach today. So let me take you through 2 cases. So the first case is this. A 25-year-old man works as a hairdresser, had a 6-week history of low-grade fever, malaise, weight loss, arthralgia, skin purpura over the lower limb, with some intermittent confusion and visual blurring. And so when you saw the legs, this is what you see. And the temperature was 38.5. He had a pansystolic murmur, and the lungs were clear and swollen ankles bilaterally. So your first thought, of course, because we don't have, it's not a live audience, so I will just answer myself. But think about it. What do you think? So when you see this and you think about it, oh my goodness, this is vasculitis. And so you think about vasculitis. So the 5 important questions that I will ask myself. The first question will be, what specific type of vasculitis is this? And so going back to that picture and going back to the table that I showed you earlier on, if you see things like purpura, vesicles, splinter hemorrhages, and things like that, palpable purpura, you would think of things like small vessel vasculitis. And remember, the small vessel vasculitis, the differentials will be things like HSP, urticarial, MPA, GPA, ANCA-associated vasculitis. And so you have said, yes, I've seen this. This is small vessel vasculitis. But then, is that the final diagnosis? That is not the final diagnosis. So you need to investigate further to ask yourself the next few questions. Is there a secondary underlying cause? Is there a condition that can mimic the presentation? And how do I confirm this diagnosis, and what is the extent? So is there a secondary underlying cause? So this is where the history becomes important. You ask the patient, ANCA vasculitis. So you remember the symptoms of ANCA vasculitis, ENT symptoms, neurological symptoms. Then you look for secondary causes like lupus, you think of oral ulcers, alopecia. I ask all of these questions. And then when you ask him more history, you find out that he recently fell down and had a scratch over his hand, which took about 1 week to heal. And socially, he's a smoker and non-IVDU. So you're trying to think of other differential diagnoses and causes. And of course, with everything, we would send an initial blood panel, and the blood panel came back as the full blood count showed low HB, low platelets, high LDH, high retic count, high bilirubin indirect predominant, and a renal impairment that was present. And the urine FEME showed RBC 10 cells per high power film with urine protein 1+ and no white cell count. So we're taking all of the symptoms that we have, we kind of put this together. This is small vessel vasculitis with hemolytic anemia, thrombocytopenia, and AKI that is most likely to be GN. And so we are already thinking, oh, this is probably sounds like ANCA vasculitis or sounds something along those lines. So we asked the last 3 questions. Is there a condition that can mimic? How do I confirm? And what is the extent of the vasculitis? And remember, with small vessel vasculitis, of course, the primary vasculitis that you see here, EGPA, GPA, MPA, HSV, cryoglobulinemia, cutaneous leukocytic cytoclastic angiitis. But the secondary causes will be things like vasculitis due to rheumatoid arthritis, SLE, Sjogren's, things like drugs, infections, and Hep C associated. And so our differential diagnosis becomes very broad. Not just see the renal impairment and think ANCA vasculitis, HSP. No, we think of infections, embolic diseases, CTDs, drugs, other things causing this condition. And so then we should work up the patient according to the presentation, as I mentioned earlier on. We work up the anemia, work up for infection, work up for GN. So all of the tests which I've shown here, I will go through it one by one. Consider the causes of primary vasculitis. And so, of course, we'll send an ANCA and IgA, and we consider skin biopsy of the skin lesions. And so after sending all of these tests, this is what comes back. Raised inflammatory markers, Coombs is negative, so it's a non-hemolytic, non-immune hemolytic anemia. Blood culture turned out to be positive with Staph aureus. And urine phase contrast did show GN. The p-ANCA was positive, the ANA was positive, 1 in 80 speckled, but the ENAs were negative. And so with this group, with this diagnosis, we have got all of these blood tests. And then we remember that the patient has got a pansystolic murmur. So we have to evaluate the pansystolic murmur. And lo and behold, in the pansystolic murmur, we find a vegetation sitting down over there. And so the final diagnosis, even though the p-ANCA is positive and so on, with GN, the final diagnosis should be infective endocarditis with septic emboli causing vasculitic-like features. And this is evidenced by the fact that the patient has got Staph aureus in the blood. So the patient has got infective endocarditis causing immune phenomena, which we know infective endocarditis can cause this immunological phenomenon to happen. So the treatment then would be to treat the infective endocarditis and manage the patient appropriately. The second patient is a lady, a hairdresser as well. I couldn't be bothered to change so much of the history. Then subsequently, there's a 1 month history of constitutional symptoms, occasional bluish discoloration over the left finger, and associated intermittent pain over the left upper limb. When you examine the patient, the right pulse was stronger than the left. The BP on the right side was higher than the left. There was a left bruit over the carotid region. And so this patient actually has got Raynaud's phenomenon with absent and weaker left pulse. And so in our head, what are we thinking about? Weaker left pulse, bluish discoloration. Oh, maybe this could be something vascular related. Other symptoms, systemic symptoms, yes. No other symptoms that could be of note. She's a non-smoker and non-IVDU. Blood tests, unremarkable except for raised inflammatory markers. And so we've got Raynaud's phenomenon with absent or weaker left pulse and raised inflammatory markers. And this is what we are considering at this point of time. And in this group of patients, we are not just evaluating the thing, we're evaluating the Raynaud's as well. So when we think about Raynaud's, we think about secondary. So she is secondary because she's asymmetrical, painful, raised inflammatory markers. She's a bit more than 30 years old. And she does not have, it is a persistent that is sitting down over there. And even with Raynaud's, the causes are numerous. And with secondary Raynaud's, one of the causes was actually large vessels. And usually this is proximal or unilateral symptoms. And this patient has unilateral Raynaud's phenomenon over one finger. So this is what we are considering. And we image the patient accordingly. CT angiogram showed no evidence of left upper limb arterial thrombosis or vasculitic features because we're talking about vasculitis, but the suspicion remains present. So we ordered an MRI for this patient, or we asked for an MRI for this patient. And the MRI actually showed a left proximal subclavian artery stenosis, which is in keeping with Takayasu's type 1. And so this patient was treated with prednisolone, given methotrexate, went into remission, inflammatory markers improved, and the symptoms over the finger also improved after that. And so this is an example of large vessel vasculitis presenting as Raynaud's phenomenon in the beginning. And if you were to think about it, patient has got limb claudication as well as part of the initial presentation. So this is why we thought of that. And if you were to put them into the classification criteria, you'll find that yes, age less than 60, evidence of vasculitis on imaging. She has all of these other features, female, age, vascular bruit, reduced pulse, and so on. And then you can classify her as having Takayasu's arteritis. So in terms of summary of an approach, you must recognize the syndrome, take a full history, recognize the mimics, decide on which vessels involved, and determine how to confirm your diagnosis and treat and decide how to monitor its response. So the last part of what I'm going through, which is basically just 2 slides, an overview of treatment principles, I would just say, if you think of vasculitis, please refer to the rheumatologist. If you think of secondary, please refer to the rheumatologist as well to have a look. So the goal of treatment for any form of primary vasculitis is different from secondary. Secondary or mimicus, you treat the cause, you treat the underlying disease and such. But in primary vasculitis, like a large vessel, medium vessel, as well as small vessel, the goal of treatment is to induce remission and then maintain them with immunosuppressive therapy. And the treatment is based on the different types of manifestations and severity. So we aim to identify and remove inciting agents, and we initiate immunosuppressive therapy based on the extent of vasculitis. I will not go into more details about this because this, I think, should be left to the realm of the rheumatologist, or sometimes this also ends up in the nephrologist's hands, or sometimes even in a dermatologist's hands. So just remember that if you think of vasculitis as a medical officer or a general physician, remember to do the appropriate initial investigations first, and subsequently, once you've got all of those things, refer to the appropriate team to have a look and to see the patient. So in conclusion, so this is my last slide and on the dot, heterogeneous, it is a heterogeneous group of disorders characterized by vessel wall inflammation. It can be primary or secondary. The classification is based on its predominant vessel size, large, medium, and small. So we've gone through this extensively. And the manifestations is determined by the type and size of vessels affected. Mimicus are common, especially infection. And think about TB as well in Malaysia. Always exclude them before saying a patient has primary vasculitis. Because if you treat them as primary vasculitis, the treatment will be long-term immunosuppression. And if we miss out a mimicker or a secondary cause that is treatable, for example, an infection, and we give them heavy immunosuppression, the patient may not do so well. So the problem with this is that there's no single diagnostic test, and it's suggested by multi-organ involvement plus compatible laboratory and or imaging findings. So with that, I end my presentation, and I'll be happy to take any questions from the floor. I hope this has been kind of like a sprint, a bit of a run through and a sprint through vasculitis. And I hope that it's given you a flavor and an understanding and given you an idea on how to approach vasculitis. Thank you very much.
Thank you, Dr. Benjamin. Thanks. That was an excellent overview of vasculitis. Overview of the various types of vasculitis that we can see, and how you go about making a diagnosis and including investigation. But I think the takeaway here is that there must be a good history and examination. That is still the basis of anything you see. It's not just see, oh, rash, refer them. You have to get a history. Oh, rash, patient not very well, joint pain, refer to rheumatology. That's not the way to go. As a general physician or the MO, as an MO in the medical ward, you are the frontline. You have to think a bit out of the box. Think a bit laterally. Get some investigations done before calling the relevant specialties. It will make it a lot easier for the person to see for the referral team to see the patient. So does anyone have any questions for today's talk, or how to approach vasculitis in general? I don't see any questions yet, or does anyone want to just shout out the question?
I think there's one question. There's one question that says that a young patient presents with Raynaud's but no signs of systemic sclerosis. How far should we work up the patient for vasculitis, or for whatever reason that is? Is it okay if I answer this question, Dr. Dick?
Yeah, go ahead. Yeah.
Okay. Yeah. So I think this is a very good question. So it's always this idea of whether we should this of course is not in the realm of vasculitis, but more towards systemic sclerosis. But I would think that if a person actually were to present with Raynaud's phenomenon, usually what we'll do is we'll of course go through the history and do an examination first. So you must confirm that this is truly Raynaud's phenomenon that shows a biphasic or triphasic color change, and ask them what is the precipitating factors and whether it is persistent or not. Then I would go through a full systemic review. So that means you'll go through all of the organ involvement. You would look at GI, everything, and you ask them whether they have any symptoms present or not, as well as family history. But I think in this day and age, I think Dr. Ding will probably agree with me, is that a lot of times now when we see Raynaud's phenomenon and we confirm it's truly Raynaud's phenomenon, most of us would end up sending an ANA first. And then if the ANA turns out to be positive, then an ENA to look for any autoantibodies. So when it comes to Raynaud's phenomenon, there is this, we try to pick up what we call as very early systemic sclerosis or VDOS. So what happens is that with Raynaud's, we will do the, we will see the patient with Raynaud's, rule out any other mimickers of primary Raynaud's or connective tissue disease, for example vascular thrombosis and things like that. And subsequently, you can send an ANA. If the ANA is turns out to be positive, then a nail-fold capillaroscopy will be helpful, and that will help us to determine what to do next with the patient. So I would say that your next investigation should be guided by the history and your examination. So check the pulses, make sure the pulses are palpable, check what are the inciting events, and then move on from there. So hopefully that will be helpful for the person who asked the question. Dr. Ding, do you have anything to add on to that?
It's always history. You need to get a good history. Sometimes the answers from the history itself.
Yeah.
Of course, again, once you got a history, you need to do investigations. Don't forget, cervical ribs is a common cause of this.
Yes.
Like Raynaud's phenomenon. Most of the time, it is just primary Raynaud's, meaning there's nothing to it. I mean, there's no underlying CTD or anything sinister.
Are there any other questions? Anybody else wants to ask anything? So hopefully the presentation was very clear enough that no one asked any questions.
Yeah. There's still 3 minutes left on the clock. 3 minutes to ask your questions.
I think there's no question from the floor. Is it okay to end the session today? There's one more question.
Oh.
How do we treat Dr. Ding, would you like to?
Primary Raynaud's means there is just no secondary cause to it. So how I would just tell them is to read them. Number 2, keep the extremities warm, keep the body warm. Avoid anything that would trigger the Raynaud's. If it's cold situations, I mean, sometimes you cannot avoid it, so you just have to keep yourself warm. If it's cold drinks, if it's like cold water, maybe you want to use warmer water, room temperature water, not really cold water. Sometimes if it's emotional stress triggering the Raynaud's, then I don't know. Yeah, you will have to find a way to deal with it. Most primary Raynaud's are it's benign, doesn't cause much problems other than the fact that the fingers change color. You don't usually get ulcers from these Raynaud's. So another question.
Yep.
Ben.
Yeah, I think
When
this
do we
is
start
a
including high-dose steroids?
Yeah, I think this is a very good question.
Yes.
Generally, it will depend on the type of vasculitis you suspect and the manifestations. So if it's a very severe manifestation, so a very classical example will be if you think the patient has GCA. So giant cell arthritis, of course, is a large vessel vasculitis. It can cause sight loss. And if you believe that the patient has got GCA while waiting for your diagnostic processes like biopsy and things like that, but the biopsy has to be done within an appropriate time as well, then in those cases, we would start them on higher doses of steroids. Or if you think the patient is in a life-threatening or organ-threatening situation, then probably those would be the time that you would start on some steroids at that point. That's what I would generally advise and do. Yeah. And then subsequently, remember that as you give patient medications, you're looking for the way they respond to your treatment. And secondly, what you want to do is you want to also make sure that you are working them up in tandem with whatever you're doing. So while you're treating them, you're working them up and trying to exclude the mimickers, you're trying to exclude secondary causes, all these things like that at the same time. Because you want to determine whether your treatment is appropriate or not, and then adjust it accordingly. I think this is the same for all patients who present acutely ill, depending on what, regardless of what the diagnosis is. Yep.
I want to add in here this if you are in a small hospital or in a KK, if there are any MOs and KK or FMS working here, if you think you have a vasculitis, please do not just send a referral call. Just call your referral hospital. I have seen some referrals from the coming as a referral from a referral letter with vasculitis. The patient will come in like a week or two after they've been seen in the KK. Then it's always a mad rush to try and get in the see as soon as possible. So if you think there's a vasculitis, just pick up the phone, call.
Yep.
We will not get angry, but we will get angry if you delay the referral.
I think I agree with Dr. Ding. I think
organ damage.
Yep. I think when you think of vasculitis or you think of very severe or manifestations of the disease, then you should call to get urgent review. I think that's a key thing. When you think of vasculitis and you think it's severe, you should get an urgent review and an urgent consult from the appropriate specialty. Yeah.
Vasculitis can be pretty mild, like just a simple like HSP, but when it does involve the eye, or knee, or limbs, that's when it gets serious, and the patient may end up badly. So that's when you have to act as quickly as you can. Another one is talking about Takayasu. If you see anybody, young person, this for more for the physicians and the junior MOs who are listening in. If you have a young person below the age of 40 who comes to you with hypertension, always check all the pulses, left and right, because we've picked up so many Takayasus who have been missed repeatedly in the KK and in other hospitals because they did not check the pulses. Anybody who has hypertension from below the age of 40 is abnormal. There's usually a secondary cause. So one of them is Takayasu and is treatable. So always check the pulses, both sides.
I agree. I think this kind of exemplifies the whole vasculitis concept. Even lupus also, for example, it is not just a vasculitis. You have to really, when you approach the patient, right, whichever the patient is, you must actually approach them systematically and wholly. You must look at all of the things. So if you see young hypertension, don't just say, oh, young hypertension, give blood pressure medicine. But what you should do is you should check for causes. And the causes doesn't mean you need an echo today. It means that you need to palpate the pulses, listen to the renal artery, listen to the heart. These are the things that is very important. So I think as physicians, our history examination is very important. And when we find, a certain diagnosis like young hypertension, like Dr. Ding has said just now, examination will be very important for you to decide what is the next most appropriate investigation for the patient. It's not just one person send every single investigation under the sun, because then you're casting your net very wide, but you're not doing any justice towards the patient that's in front of you.
Since our time is up, so thank you, Dr. Ding and Dr. Benjamin, for the session. I hope everyone have clearer picture of vasculitis after today. So I will end the session today, and please join us next week for the next topic.
Thank you. Thank you, Ben.
Okay, thank you. Thank you.
Thank you, everyone. Have a good day.